the incidence of injuries in football and the most typical injuries during the competition. So, oh, wait one moment. Yes, perfect. So in this one, you can see the first study with more than 3,000 injuries identified from Clade and collaborators. So they study a systematic review of the epidemiology and ethological aspects where we can find the conclusions, the location at the high risk of injuries, where the lower limbs, particularly the thighs, knees, and ankles, are the most identified injuries, or the places where we can find the most identified injuries. So in the second review, the results are confirming the line of the first study. So Alejandro Lopez and others show us like height is the most typical place, following knee and ankle, okay? And if we go a little bit more forward, we can see that soft tissues involucrating muscles and tendons are the main common issues that we're going to have in professionals football injuries, okay? So last one about these main things is the comparison with the MLS incidence of injury approximative study from 6 years, okay? And also they have the same results as Extran and collaborators taking more than 1,500 professional European soccer players in Champions League. So we identified the hamstrings, adductors, and then ankle like sprains, like common injuries. So as you can see, the different reviews are giving us more or less the same information. So what about psychotherapy in relationship with treatment of acute injuries? So first of all, we have an evaluation from how we can treat acute injuries. We are coming from police to peace and love protocol, where we are trying to avoid completely rest, moving to the load all the tissues, and then changing the paradigm about treating the science, the icing of the injuries, moving forward to the vascularization of the injuries, trying to increase the microcirculation. That this is very important. So if we start to speak a little bit more about psychotherapy, we can see that the different modalities, how capacitive in the left side, we can concentrate a lot of energy in the surface, but then because the mobile electrode is going to make the main implants, we are going to lose the energy very quick in comparison of the resistive modality, where the own tissues is going to take the energy. So we're going to need a little bit more time in order to have the peak of energy, but then as you can see, the decrease is more progressively, okay? So that means that we have 60 minutes of really high effect, and this is gonna come back until or after 8 hours. So if we take a little bit more deeper, we can see the difference that what we are having in the surface, what we are having in the joint, and what we are having inside the joint. So as you know, guys, or more of you, surface, the capacitive high power is the one who's going to concentrate more energy. But in contrast, inside where we are going to the joint, the capacitive is not going to penetrate. So in that case, high power resistive, the gray line, is the one who's going to take more effect. And then inside the joint, again, the high power resistive is the one who's going to give us more results. Okay, if we start to see or speak a little bit more about muscle flexibility, viscoelasticity, tissue temperature, and blood circulation, we have this interesting study coming from a Japanese group who they study what is happening also with the hemoglobin concentration with a really great results. So we can tell that we can increase the concentration of the hemoglobin of the muscles, okay? And they can include that capacitive and resistive is going to be an efficient method to prevent and treat musculoskeletal injuries, okay? And again, also is going to work good on the viscoelasticity properties, and at the same time, we can improve blood circulation. more or less in the same line, or more, if we can concentrate a little bit more in the microcirculation, that is one of the key things in degenerative tendinopathies, okay, because we have an hypoxia because the compression, okay, and also for muscle injuries in the acute phase, that we know right now that it's very important to increase the microcirculation in order to develop the satellite cells and have a very good scar, okay. We can find a really good statistically significant differences, okay, with the treatment of therapy in this kind of tissues that is going to provide us these effects on the injuries. And then I want to speak to you a little bit also about not an injury, but something that we can find a lot in a sports injury, that is like this delayed onset muscle soreness and his functional recovery. So if we have two groups, the control group versus the Winback group, we can see that after 25 hours of the protocol, okay, according to the results, the taker group was show an effective recovery in comparison of the other one, and also after 72 hours, it seems that the taker group is having better results in terms of performance, like squat jump or something explosive. Okay, so this in a sport like football, it's super interesting. Okay, and then I'm gonna introduce you the last two papers, because we found in the scientific articles that ankle and knee is one of the common places where we can have injuries. So this one is super interesting because they do the study with a Winback device. So of course, when we have an ankle sprain, if we do a correct treatment, after 10, 12 sessions, we're going to recover the edema, we're going to recover about pain and the ankle performance. But if we compare about the velocity of the recovery, we can see that just after 6 sessions, the Winback group was faster and better results than the control group, that they also are having treatment, but the only difference is that one group is doing also Winback treatment, and the other one also a normal treatment with massage, compression, and other stuff, okay? And finally, in terms of flexibility or the viscoelasticity of the tissues, this is very interesting because they studied the benefits of Thecke therapy in deflection in a anterior cruciate ligament recovery. So you can see that Thecke group versus control group after 4 and 6 weeks, like always, the Thecke group, okay, is getting better and faster results in comparison with the other one. So this is going to allow us to start to do more active stuff, or like, for example, to introduce the bicycle before than the other group, okay? So in that case, we can see, like in elastography, ultrasound, how we can, from intervention to post-intervention, we can improve the blood circulation and the viscoelasticity, again, the elastic part, before getting inside the plastic area, that this is very important for soft tissues. So in conclusion, if we go to this study, we can say that this device is gonna increase the healing process, and is one device that is gonna give us the possibility to use it in acute phases, reducing the risk of complications about motor actions or immobility. So this is my brief introduction, and now I'm gonna give you again the managing of the webinar, Paul.
Okay, Ignacio, that's great. Thank you very much. So there's a real group building here. Got about 59 people on the call, which is fantastic for a Thursday night. What I'm going to do is, so I mean, in terms of Thecke therapy and its application, if there are people who this is new to and you want to learn more about this, obviously reach out to us. We'll follow up with some information. We'll share that presentation. You know, we're obviously, you know, able to come and visit you in clinic or at your club and what have you, and go in a bit more detail with you at that point. So let's pop that together. So thanks to Ignacio. I know there's a lot of time and effort went into that review. So muchísimas gracias. as they say in Barcelona.
Thank you very much.
So let me open this up more broadly now. So we've got, if I can ask the panelists just to unmute a little bit, and then what we're going to do is people come in. You may see me sort of letting more people into the group, but what we said we'd be talking about tonight is the acute injury management side of things. And if I could maybe kick off with you, Wayne. I mean, the first question here was really, how do you think acute injury management has changed over the past, 5-6 years or so in your experience?
Yeah, can you hear me, Paul?
Yes, loud and clear.
Okay. Yeah, good. Firstly, Ignacio, thank you very much for that presentation. I think it covered a lot of the groundwork for the benefits of techotherapy. Personally, I've used techotherapy in a limited way with San Antonio Spurs, so I have some experience, but I'm certainly not at the level that the rest of these guys are. So I'll defer to them in terms of the benefits of the techotherapy, but on acute management, Paul, what I'm really interested in and where I've diverged a little bit is more into the soft skills side of things, they call effective skills, where I think therapists need to be a little bit more aware of their communication, how they talk to players. The other thing that I've seen change a lot, certainly in my last few years, is this athlete-centered model for rehab, where in today's world, it's not you just tell the athlete what to do. You have to ask them, you have to engage with them. And there's basically four pillars that I see with that. And the first is engaging the athlete, where what we did is we made the athlete basically the CEO of their rehab process. So they were the decision maker in a lot of sense. But what that involves is an empowerment thing where we have to educate the athlete. So the education piece is what I find really helpful, and what is sort of taken me to the Winback group is because of your commitment to the education. So what I've found is that if the therapist doesn't fully understand the benefits or the use and the way in which to use the machine, they're not going to get the results that they should get. So in order to get this process right, you have to educate these athletes, because they've got to make an informed decision, and that's what it's about. So it's about the empowerment of that athlete. And then we had feedback where we had regular meetings and transparency. So that whole return to play model has changed significantly in the last few years, where the athlete is becoming a lot more involved, as are the agents, as are everyone else. So whatever decisions we're making on the therapy and the acute management of it, we have to educate the athlete, we have to get them involved, and we have to do a lot of it. So, that is something that I found certainly changed for me significantly over my time in the US, in San Antonio and the Miami Dolphins. Something else that was I wanted to draw attention to is a more linking of the functional assessments, where we're looking at a kinetic chain along the whole body, where you're looking at movement patterns, you're looking at things rather than just treating the hamstring strain, getting rid of the pain and the swelling. You need to understand what caused that, where in the kinetic chain these problems are. So that is a much bigger role that we're looking at today in the management of these injuries. You can't just simply say, okay, we've diagnosed that he's got a hamstring strain, and we'll treat the soft tissue injuries and he'll be better. What happens? He gets a recurrence, and you'll still see that the numbers and the incidence of these hamstring strains haven't really changed enough to prove that we're doing a good enough job. So I think it's on us to start understanding and looking at other things and saying, what is causing this thing and how do we prevent it, rather than just looking at what's optimal to treat it. And then the other things like questionnaires have become massive again in the last few years, where certainly on the psychological aspect of it, where they're recognizing the role of mental health and mental responses to the injuries, how players are coping, those who cope, those who don't cope with the injuries, and how do we do it. So what we did is we had these IPRRS, is that psychological readiness in the return to play. And that was a simple questionnaire that the player would complete, and then that would tell us whether he felt confident in going back. So that's, I know it's not an acute part of it, but we need to start getting that so you know exactly where you are in your return to play protocol. So those are some highlights quickly, Paul. I know they're not therapies per se, but where the Winback comes into that thing is I like the movement side of it, where you're involving them, you're getting the movement during the treatment. You're not just passively lying there. That's what I loved about the machine and got me involved in the San Antonio Spurs. But then again, that education part, I think that is critical for me.
Tremendous. Well, that's fantastic. You cover a lot of ground there, and that's one of the things we're trying to do in these evenings is make sure that there's a lot of rich experience and that people can share and sort of get some insight. So Phil, maybe same sort of question to you then. So, listening to what Wayne was saying and just looking over the last, 5-6 years or so, how have you seen things evolve?
Yeah, I think for sure I would agree with Wayne that obviously I think educating the players and making sure they're involved in that decision-making process is hugely important. I think from a more kind of clinical perspective, things that I think have changed in the last sort of, maybe 5 to 7 years in the certainly acute injury sort of state would be probably the application of the actual treatments to the players. So I think maybe 6-7 years ago, there was a real rush to get the ice out as soon as you could do. And, that was the go-to treatment for any kind of acute injury. And I think in more recent times, people have started to follow some of the evidence on that. I think the evidence was probably there 5-6 years ago that ice probably wasn't the go-to thing in terms of reducing inflammation, but perhaps it helped with pain, but probably isn't that effective at reducing actual inflammation, per se. And I think people now start to catch up with that a little bit. So I feel like now, in terms of how I would approach an acute injury these days, rather than, perhaps there's still place for ice in terms of reducing some level of discomfort, but I think in terms of reducing inflammation, I would tend to even get the Winback on there early doors and start trying to look at lymphatic drainage, trying to target the vessels around the popliteal region and the inguinal region to try and actually aid some of that lymphatic drainage and in and alongside the elevation of the limb with a lower limb injury. I think compression is obviously fairly important in terms of reducing that acute inflammation and swelling. So yeah, I'd say that's kind of where I've gone from a clinical perspective. And yeah, I'd certainly agree with Wayne in terms of that sort of psychosocial component. I think back to sort of maybe even longer ago, sort of 7, 8, 9 years ago, at the club that I was at, which was Wolves at the time. And I think things have changed an awful lot, both in football and perhaps kind of from a sort of society's expectation of how you speak to people a little bit in the last few years. And I feel like years ago, there was a real push to sort of keep people in the building. We sort of get the injured lads in at 9 in, they'd be there till 4:30 in the afternoon. It's almost like a punishment, the fact that they're injured, they needed to pay for being injured and sort of be seen to be working harder than the rest of the guys because I think on reflection, I feel like now looking back at that was completely the wrong approach, because actually you probably made them, psychologically lower than they needed to be. They felt they were doing stuff that the rest of the guys weren't having to do who were fit, and probably actually had a negative impact on them in terms of their recovery. And yeah, I feel like that's sort of changed, and I think that's kind of going out of the game now. And people are starting to take the psychosocial elements much more into consideration when they're sort of planning and dealing with these kinds of injuries.
Yeah, well, I think there's a kind of treating people as adults in many ways is, yes, you're a professional sports person, but hey, people have got to think things through. So, Phil, thank you for that. James, tremendous that you could join us from the States. I don't know what part of the States you're in. Can you share that? Not who you're with or what have you, but which city are you coming in from?
New York.
Oh, there you go. Can't be bad.
Not bad.
Same question then. I mean, obviously, you've got huge experience across, multi-sport clinics, Olympic level, etc. Just that, adding something to what the guys have been talking about. What would your kind of your sense of the last 5-6 years? What's changed, in your opinion, in this approach to acute injury management?
So I think there's probably a couple of points to make. Firstly, is just to echo Wayne and Phil with all of their overarching statements, that I definitely concur with all of that in terms of centered approaches and managing the holistic kind of component, whether that's the athlete, the wider picture. Certainly if you're in team sports, coaching influence, agent influence, family influence, the financial impact of all of this influence, that acute setting, and how you manage and sort of calm the noise and the distraction around it is key. Yep. I think to go into some of the specifics, I'd probably turn around and say, look, for a long time, if you go back to the original think tank that was done back in 2007, 2008, with a lot of the leading lights around muscle injuries and acute management in the first 48 hours, certainly in athletics, we ran a 1 or 2 day seminar just on how to manage the first 48 hours of muscle injuries, which tells you how complex that first 48 hours is.
Yeah.
There's a lot going on there in terms of what you're doing. Certainly, when you looked at that paper that was published in 2007, 2008, it's very opinion-based. I think now we've moved to much more evidence-based and really starting to test out the science. But more importantly, and I think Ignacio touched on this really well, is you've got to adapt your treatment according to which tissue is injured. So you're not going to do the same approach to muscle injury as you are to a muscle tendon, as you are to a tendon injury, as you are to a ligament injury.
Yep.
It's not going to be the same approach. And within that research review that Ignacio did, we've got soft tissue injuries as a unit, but not all soft tissue injuries are the same, not all MT junction. So an MT junction of short-headed biceps is very different than an MT junction of long-headed biceps injury. And so I think it's then understanding how we can influence that in the acute setting, and then how we can get as quickly as possible to movement and load where appropriate, where we're not overloading, because if you overload too early, you'll get poor scar tissue formation, because you'll get excessive scar tissue. But if you load appropriately and actually deload, and the evidence is coming out more that within that first 48 hours offloading, and that's where your protection comes in, actually helps to allow those fibers to bind. You don't get so much scar tissue formation. You get a reduction in the incorrect collagen being laid down, because if you overstimulate the body and the brain, in essence panics and lays down too much collagen rather than effectively getting bridging between the tissue damage. So I think those things are important. I think certainly the use of TECAR in addition, so we've used electrical stim for a long time because it reduces plasma proteins into the environment, which helps with edema. And that's where, again, things are, I think, you know, to put Phil's comments into perspective, that's where ice comes in, as opposed to necessarily inflammation, where we want the inflammation there, but we also want to reduce the edema, because the edema creates a pressure pain threshold, which causes muscle inhibition. So you're constantly fighting around how do we manipulate all of these different chemical components and physiological components that are part of the normal healing process versus an excessive healing process. And some people will have an abnormal healing and some people have a normal healing. So it's how do we look at markers in the early acute stages that gives us a gauge? Is this tissue responding appropriately? And how specific can we be to that? And I think that's the level of detail that we've evolved to, where we weren't 5, 10, 15 years ago in our practice.
Yeah, no, that's really interesting. I mean, I think the first three guys, you covered a lot of ground there. And to your point, James, you can run a 3-day conference on the first 24, 48 hours. So, you know, I think getting people thinking deeply about it is an important thing. And, you know, how all those different tissues respond, you know, it's a complex environment, but the better informed, that's also taking all the information in and then, you know, choosing a strategy that's right in the environment that includes, you know, the player's health, everybody around them, the manager, you mentioned the team, etc. There's a lot of pressures that are external to the player, but impact in the environment itself. So thank you for that. Pablo, same sort of question. I mean, from your perspective, you know, coming from first team football in Burnley and through into private practice, you know, you look at the past 4 or 5 years, do you see a difference between how you would approach things, for example, in you know, the first team versus somebody coming in on a Monday morning with an acute injury, you know, weekend warrior, or somebody who's done something more acute in the everyday world, just as a question?
Yeah, yes, of course. Thank you everyone for your input. A lot of ground has been covered, to be fair, and in detail. So so I'd say probably, especially, you know, in elite sport nowadays, I think they look in an external help. Everyone try to improve in every aspect. I think psychology is very important, as has been mentioned, but loads of players or athletes are looking for help outside of the club, outside of the institution where they are, and that could be good because they're trying to improve, but at the same time can, you know, influence certain things in a negative way. So, for instance, if the communication is not there, you know, the club might be doing something that the private physiotherapist is doing, and so I think that's fundamental, especially because I can mess up with the psychology of the player and get misinformation. So in that, the pressure, obviously, to get players quicker. For me, I think one of the main things that perhaps, you know, a few years ago you could see was a bit more like I think James mentioned when you put ice and compression ice and that's it and leave it for 2 days. But now, you know, things have evolved, and I think obviously every injury is different, but you're looking a bit more into early loading if you can. Of course, as James explained, the different type of collagen. So sometimes rest at the beginning is very important. If you have a muscle tear, you like type 1 collagen, so the scar is set to be stronger if you're not in activity. But afterwards, you want to start activity as soon as you can to lay type 3 collagen, so the scar is stronger. Within that, I think the take-care is a massive help. So for me, if someone comes in to my clinic on a Monday morning, obviously the pressure is different. I'm a bit more relaxed to do what I think I should do. Again, you have to be careful with, again, what they're doing at the club, what are the protocols that they follow. But I think psychology there, again, I think is very important with the pressure, how you manage what you say. And if the player is positive, like I think Phil mentioned before, that at Wolves they used to bring the player and keep it till 4:30, and it's almost as a punishment, yeah. So obviously the recovery is going to be different, because I've seen in players where they could have a great tear and be psychologically not in place, and the injury will take a lot longer to recover. So I think that is very important, especially nowadays with many things going on. You have the social media, it has a massive effect. So I think, I would say everything has become a bit more scientific, which is very good. Again, for me, sometimes it's very important to follow the player sensation. Often we go through, if you do a scan, for instance, and you said, oh, the scan says you got grade 3 tear, that's going to take you, 10 weeks that came in the psyche of the player. So I think always it's important to keep that sort of positive mindset. You go week by week.
Yeah, that's great. Tremendous, Pablo. Thank you for adding some more in there. Just one annexed question to this, just as a general question. Pete, I'm conscious we haven't brought you in yet, but as we talked about, we'll kind of bring you in later on in the discussion. But do you find that the patient presenting today in the private setting is much more informed? I mean, are they coming in with ideas, this is what I've read here, there, and everywhere? What's the kind of, has the patient changed? Maybe professional football is one thing, but in the everyday world, do the patients come in with a lot more information? And what would you say the quality of that information is like, just to broaden it out? And final point on this question. Wayne, do you want to pick that one up?
Yeah, certainly I can start to that, Paul. I think it's a mixed bag, really. They're certainly coming in with a lot more information, but I don't always believe it's the correct information that they've got because of the access to Google and a whole lot of other websites. They're getting information, and often there's a lot of misinformation. Yes. So again, that goes to my education piece, where if you wanted to get informed consent, you have to educate the athlete. They got to know, but you got to spend the time and listen to them and find out what it is that they believe, where they're coming from, and where they've got that information from. And you have to address it, because if you don't, you're not going to help them, and they're not going to believe in what you're doing. So I think it is critical, and we have to accept that they are going to come in with a lot more information, be that good information or fake news, as they say.
Yeah. I guess it's difficult to sort of, you've got to percolate your way through that as clinicians. And then generally to the rest of the panel, anybody got any further points on this this first question that you want to raise, Pete? If you want to add anything from your side, or Ignacy, obviously we've given you a bit of a breather, but anything your own experience over the last 5 or 6 years, Pete, can you comment on how you're seeing this sort of acute injury management evolving?
Yeah, I think kind of obviously a lot off the back of what the guys have said. Obviously, I see very few acute injuries, but obviously see a lot of injuries kind of 6-8 weeks down the line. And I kind of agree with what the guys are saying with, I see as many troubles at 6-8 weeks with players not doing enough early on to do it. Some players doing too much early on. I think there is a very fine balance between the two. And I think obviously, like the guys were saying, the pressures from club managers, agents all feed into that a little bit as well.
Yeah.
And obviously when you go lower down the leagues as well, just players from a contract point of view and having pressure put on kind of from that side of things, a big influence on how they rehab. I think as well, off what the back of the guys are saying, I think a lot of players come to me with not the best knowledge of their injury and just a little bit of help and a little bit of guidance on the exact stage of the rehab they're at, what process they need to go through next, and how you're going to get them there really feeds into the recovery. And I might only see a player for 4 days in the week, but kind of at the end of the week, they feel much more comfortable with their injury. I'm not saying they're further ahead in the rehab process at all, but they kind of have that insight into what they've got to do next and where they've got to go. And I kind of find they leave in a much more positive position than they came in the week, just because you've imparted that little bit more knowledge into them and almost given them a roadmap of, right, okay, I think, like Pablo was saying, right, almost timeframes, I think kind of are a little bit old school now, really. It's kind of, right, okay, when you've hit this goal, we can then progress on to the next thing. When you've hit this goal, we can progress on to the next thing. You can give them an idea of a time frame, but I think kind of you giving them goals they've got to hit at each phase, and then they understand that. And then rather than just being, right, in 2 weeks, you can do this, when physiologically they might not be able to do that from a recovery point of view, they might not be able to do that like you expected, which a lot of players don't progress as you expect. So I think if you give them goals to follow, it kind of helps the player out a lot as well, if they understand that process.
And I guess I'm guessing there'll be some players that want to see the whole thing. You know, this is the end point, and there's some guys that are going to want to see a shorter time frames that get me to point A, point B, point C. So I imagine as clinicians, you've got to judge that, you know, from the sort of the environmental point of view as to, you know, where you are with each individual. So Pete, thanks for that. Ignacy, so the final point on this question, I think we've covered a lot of questions.
Yeah, I think that my colleagues say a lot of things that maybe coming from my presentation, I want only to say that currently what we are doing in acute injuries has evolved a lot. So basically, in terms of activity, we are avoiding complete rest, okay, whenever it's possible. Then second, the new paradigm in which whenever it's possible also, we will take care of the microcirculation instead of avoiding hypoxia, okay? And also working on the viscoelasticity of the tissues and thinking in the properties of the tissues. It's key. It's one of the keys to this evolution of the operation. And coming from some years ago to what we can do right now, Winback devices offer us a lot of possibilities.
Tremendous. That's fantastic. Thanks, Ignacy. So the second question was really designed to see not just techotherapy, which is obviously, you know, our bailiwick, but are there other technologies out there that you've seen evolve? Because I mean, our philosophy too is that you're going to be combining a lot of different approaches. You know, one thing isn't going to hit absolutely everything. It's just not reality. But are there other technologies that you've seen evolve over the past 5 or 6 years? And is there anything on your horizon that you're particularly interested in, that you, from a medical device technology point of view, that you think would be perhaps coming into focus as we look ahead? So maybe Phil, and there doesn't have to be, so I'm throwing it out there. Phil, do you want to pick that up?
Yeah, I'll try. I think I think that things have changed a lot in the last 10 or 12 years. I think when I first graduated, which would be going back to like 2005 or so now, I feel like there's a real push then to sort of avoid electrotherapy, and electrotherapy was seen as the sort of fluffy placebo thing. Yeah, I mean, no, like there's no one at that stage, I don't think, that was certainly in the UK that was really using that and really thinking that it did what we thought it did at the time. And I feel like as per the technology and our understanding of the way that we can apply some of these technologies has evolved, we're now able to integrate that, the various different bits of tech into how we operate from a kind of treatment and rehab perspective. And I think, as you've tried to do with the Winback, trying to take it away from being a very passive modality into becoming more of a sort of active, or certainly semi-active modality, has been an important part of that. And I think from my personal experience, that a lot of that came from working with some guys from Spain and Portugal who were using technology a lot earlier, I think, than most people in the UK were doing. And I think because of that, there was an expectation, certainly of some of the players at our club who've been playing in those countries primarily, to be treated in a similar way. And I think in my own personal experience, it was very much a case of they came to us and sort of said, look, in Spain or Portugal, when we had a muscle injury, we were doing these things, and it really got us back quicker, which then sort of prompted me to go away and start to investigate some more of these things. And I think that's when we found the tech therapy. We started to use the laser around the same sort of time as well. And I feel like, having spent some time trying to look at what happens from a kind of physiological perspective when you apply these technologies, really helped me progress the way that I treat players, both in that acute phase and also as you go into sort of the mid and end stage of rehab. I'm not sure if that answered the question or not. Really.
Yeah, no. I think it's great because at the end of the day, I think it's like anything. If you look at the mobile phone 15 years ago, you made a phone call on it. You look at what we do on it today, and a lot of people, we see this quite a lot. We start to talk to people originally that there is a kind of electrotherapy is the devil's work, it's in the past and all this kind of stuff, but things have evolved enormously and at the correct pace, because I think there are technologies that run up far too far ahead and then just collapse. So I think one of the things we've seen with techotherapy, it's been an iterative process. It's built up over time, and we've tried to integrate a lot of the therapists and clinical perspectives into how we develop things. And I think the technologies that are coming through are standing the test of time. So it's just quite interesting to hear that. Wayne, from your side, I mean, do you see anything on the horizon, as well as maybe just thinking about technology that has evolved? Do you see anything that's on your radar that's coming through?
Not so much on the horizon, but what I did experience, again, to the latter part of my time in San Antonio, was shockwave therapy. Certainly the radial experience of the radial shockwave therapy, and it was again introduced by ankle specialists in the US, where we had a player that had just very recently undergone an internal fixation post stress fracture of his fifth metatarsal. We had some bony issues going on, and they recommended shockwave therapy almost from week 1, week 2. So he had quite extensive shockwave therapy on, and the healing was significant. So, but from following on from that, then I started using it a lot more with the players. We used it for a lot of our Achilles tendon issues, chronic tendinopathies and things. And again, I had significant results, and I think those results got even better with the use of diagnostic ultrasound. So once we could identify where the lesion was, what the tissue was. Again, it was help the education and the buy-in from the athlete. We could show them the issue on the ultrasound, do the treatments over a period of time, revisit it again, and show them the improvement. So again, that's all about the buy-in. It's about getting this consent. It's about understanding. And shockwave therapy was something that there was a huge buy-in from a lot of the athletes. One is because I think it was a very simple, easy to carry out treatment. I had no real side effects from it. The pain was obviously fairly significant, but it was short-lived, and they were happy because the treatment didn't go on for ages. It was a 5 to 10 minute treatment, and you're done with. So that was the one thing that I saw a lot of good improvements, and certainly over the last 5 years. And the buy-in from the players was huge.
That's great. No, that's very interesting. I mean, and we do a lot of combination work with combining techotherapy with shockwave therapy to kind of integrate those two things in the appropriate patient, obviously. James, just same question to you. I mean, maybe thinking of what's evolving. Are you seeing anything coming through the kind of work that you do where you're thinking this is interesting, that could be, from a technology point of view or from an approach point of view? What's your perspective?
I don't know is the simple answer. I don't think there is anything that's particularly revolutionary in terms of something that's really new and really unique. I think the understanding of what we're doing and how we're doing it, and the integration of what we're doing and how we're doing it from a pathoanatomical point of view, as in where's the structure, from a pathophysiological point of view, what chemistry are we trying to change, whether it's the microcirculation, whether it's trying to desensitize, stimulate cellular metabolism in some manner of speaking, and then the integration into movement and load, all with a better understanding of what the outcome needs to be and being able to work your way back. So I would say that the evolution of the management right now within the acute setting has come by just a more detailed understanding of what is the process that's going on. And so I'd encourage the audience, if they haven't done that, to go away and read some of the science around the process of the injury and how they influence that, to understand how they integrate with the other disciplines, as everyone's talked about, whether that's strength and conditioning, psychology, nutrition, etc. This is not localized to the medical world. It needs to be an integrated process. Yep. And then understanding the outcome of where you are, because if we know the outcome of what we're trying to get the player back to, we can return somebody back to running and return them back to sport, but that doesn't mean we've returned them back to performance. And so it's understanding that end goal better then influences what you may or may not do in the early stages of that process. So I'd almost say it's, rather than something new, it's just a deeper understanding and a deeper utilization of that knowledge.
No, I think that's a great perspective. It is, understanding is going deeper. Things are moving off the agenda, and more focus is on, the things that are beginning to sort of show their mettle, whether it's in diet, technology, mental health, physical approach, strength and conditioning, and then integrating the whole thing together. That's great. Fantastic. Thank you for that. So look, we covered a lot of question 2 in question 1 combined together. So with an eye on the clock as well, the final question was really to kind of offer up to the group, if you had one thing that you had to take away and you were to say, give me one thing that is going to make a difference to me, tomorrow morning in practice in this area of acute injury management. I know it's not an easy question. What would that one thing be? And I'll throw that one first to you, Pablo. So what would be your advice, the one thing that you would give, the golden nugget, so to speak, to the group here for tomorrow morning? Not an easy one. Yeah,
it's a tough one. For me, would be 2 approaches. One would be to understand, obviously, like techotherapy, although it's been here for years. For me, and my experience is that every time I have a contact with someone, I'm learning of the technology, learning about how it affects the body. So I think it's very important to communicate that, as Wayne said, informed consent, because I feel that when I explain that, when the patients ask and I explain them, they actually, it's almost like they buy into it, they understand it, and I feel that the effect is a lot better. And I think obviously that has certainly a placebo effect. So it's very important, I think, for us to understand how the body works, how the Winback precisely now affects the body, and the benefits, because I think they're incredible. And on the other, another thing which I think is perhaps goes hand to hand is almost like, at the same time, not relying too much perhaps in sort of MRI scans and X-rays, and feel the individual, how it feels, how it's progressing, and adapt at every moment. Because, like I say, I've seen cases where something might come from a scan and say, oh, this knee is really bad, but the player is actually not feeling it. And the opposite, you could go and get the scan and don't find anything, but the player can run. So what do you do, right? So for me, using your knowledge and using technologies that are available, like the Teca, adapt and progress, and don't be so structured. Don't know if that was a bit too much, but
oh, that's good. No, it's a free flow, so I appreciate.
Yeah,
and that there's a lot of rich information. Pete, I know again we talked about your position, but again, thinking of your acute injury hat on, if you were given a bit of advice, the one thing, what would that be if there is one thing? But what would you kind of say? Right, that's that's a takeaway.
I think for me it'd be understanding the structure that's injured, and then protecting that, but then not being afraid to move the rest of the body or work muscles around that injured site. I think kind of that's the main thing. I think when you're working with players, they like to be doing things. The last thing they want to do is just totally rest.
Yeah.
So I kind of think we know kind of getting the body moving, getting that blood circulating is ultimately going to help the injury as well, and maybe kind of reduce that return to play time. So I think kind of with the structure that's injured in mind, make sure that's safe, but then get the rest of the body moving and everything working around that injury as much as you can in the safest possible way.
Tremendous. Appreciate it. Thanks very much indeed. Ignacy, just bring you back in there. The thinking is, the one thing you take away, the one piece of advice, what would your take away from the group be?
I have in mind one key, that is the word versatility. Why? Because Winback allow me to treat really acute injuries until really degenerative problems in full range of different tissues, okay? Versatility, because Winback allow me to treat manual therapy and at the same time active therapy, that right now is key, okay? And versatility again, because Winback has full compatibility with other modalities. I mean, laser is photobiomodulation, shockwave is mechanotransduction, and Teca therapy, we're creating an electromagnetic field. So it's a full versatility device and technology.
Great stuff. Thanks, Ignacy. Appreciate that. Phil, what would your kind of the one thing be if you take the meaning of the question? One takeaway?
Yeah, I think the one big thing that I think I reflect on and would change potentially in the last sort of few years of being a clinician in elite football would have been that I don't think we did enough imaging of hamstrings 5-6 years ago, and it perhaps goes against a little bit of what Pablo said there slightly. But my reason for saying that is that I felt that maybe around sort of 2014, 15, there was a real reluctance from our department, certainly, to MRI muscle injuries. We felt, we've got enough abilities within the department to assess things effectively, to not need imaging of some of these injuries, because we felt like we could get all the information from our clinical diagnostic testing and perhaps our limited ultrasound abilities as well, which, on the scanner that we had at the club, on reflection, was nowhere near detailed enough to give us the information that we thought we were getting. And I feel like what happened there was we ended up with quite a few re-injuries because we were missing some of these intratendinous injuries, especially around the hamstrings, the sort of British Athletic grading system classifications 2C and 3C, we were just completely missing, and we would get these guys back to what we thought was pretty full function at sort of 4 or 5 weeks, and then they'd go and do a couple of sprints in training and they'd have a re-injury, and we thought, perhaps we'd just been unfortunate there and had a unfortunate incident, they'd re-injured, or perhaps there's something that we'd missed, maybe they weren't strong enough. But I think on reflection we just didn't know exactly what we're dealing with at the outset, and had we had some imaging to support our diagnosis there, would have probably recognized the central tendon component and then potentially taken longer with them to build them up to that absolutely sort of end stage of rehab and return to competition. And I think that for the sake of a £300 or £400 MRI scan, I'd say it's worth investing that in the short term to give you a much better outcome at the back end of it. And I think, I'd certainly make that argument. If I was in a club, I'd be making that argument to the people in charge of the budgets, because I feel like, it's a small amount to pay to get your players back and keep them back once they are back. And don't just know it's going away from treatment and away from the topic of the evening, but that's one big thing that I would change done differently.
I think it's different, and that's what makes it valuable. So I appreciate the perspective on that, Phil. Wayne, so same question to you, and then we'll follow up with James. And so the one big takeaway, based on your experience, acute injuries, that you'd kind of point people to, that in your words.
Yeah, right. Well, I'm going to stick with the theme that I've started with today, and that's autonomy. I believe that it's the player's right to make an informed decision about their own medical treatment. And what does informed decision actually mean? It relies on knowledge, and the way you get knowledge is through education. So the way that happens is that we as practitioners have to educate the athlete, whoever is getting involved in the treatment process, and say, this is what the problem is, this is why we're using this machine, this is the diagnosis. So everything that everyone has mentioned falls into that category, where we have to make an informed decision on, this is a different type, this is a tissue that we're dealing with, this is the effect that we're having with the device that we are using. So autonomy, to me, has got to be the cornerstone of everything that we're going to be doing. And that you've got to start from the acute stage. You've got to get that right. You've got to get the buy-in from the player. And once you get that, I think the chances of you having a successful outcome are far greater, and maybe even better, as if you don't and you have a disaster, that player is not going to turn around to you and sue you like you've seen in the media and you see everything else going on, because they made an informed decision. And at the end of the day, we are mitigating risk in sport. We are allowing them back knowing that they can get re-injured. Something else may happen. But the less that they know and the less that they were informed, the more likely you are to end up in trouble. And now we're talking about World Cup. We're talking about seriously professional athletes that are on a lot of money. They need to be informed properly. And that's our duty now, is to start having a look at it and spend that time and making sure we give them the right treatment, the right advice, the right diagnosis.
No, that's a great point. I can sense the passion coming through on this, Wayne. That's a great point. That's tremendous. That adds a lot to the debate. And James, from New York, because you're earlier than the day than we are, you obviously you've got a bit more life in you. But just that same question, just to close things out, and then we'll open up some questions. And what would be your? I know it's not an easy question, but what would be
that's right. I'm going to deliberately polarize the answer, not because I disagree with anything that's been said. I agree with everything that's been said, but I think to just deliberately offer a slightly different alternative. I think the emphasis on injury at the moment is to get a structural diagnosis. A lot of the structural diagnosis systems, the classification systems, are probably not good enough. They give us a direction, but they're not good enough because they don't really give us the detail. MRIs and ultrasounds are two-dimensional image on a three-dimensional structure. So we need that, and I think it's important to have it, but it's more important to have it in the intermediate to advanced stages and the prognostic factors. It is important to have the conversation with the athlete to tell them what's going on. But if the question is around the acute setting is tissue damage, but it's also a biology and physiology. And in order to have the understanding of how best to manage this in the acute setting, it's going back to your biological and physiological principles of what is happening. That then brings in everything that Ignacio talks about in terms of the use of Winback. It enables your education, and it enables effective short-term management to empower the patient on what to do and what not to do, as to whether you are going to immobilize them against their frustration, or whether and offload them, or whether you are going to overload them, understanding the chemistry and what you're trying to influence. And then that best enables you to move people forward from a structural point of view, because a lot of the chemical processes, albeit with different tissues, are largely the same. And the biggest thing I've seen in the last 10, 15 years is that we've had opinions as to what we should do in that first 48, 96 hours, but we haven't really known. And we've thrown lots of stuff at it, as opposed to having a very directed approach. So I would challenge the audience to go away and read a bit more around biology and physiology to enhance their knowledge, to then enhance their communication and their empowerment of the athlete, and then better understand how the chemistry can then influence the structure that you're dealing with, the anatomical tissue that you're dealing with.
Tremendous. Yeah, I think you've captured an awful lot of things there. That's the nice thing about this kind of event and this kind of a discussion is that, you know, we've got very rich experience and also, you know, different points of view, which is great. Fantastic. Thank you very much. So listen, we've got about 10 minutes before we kind of wind things down. So first of all, you know, I want to thank obviously Nazi again and all the panelists for contributing in the way they have done tonight. So this is recorded. We'll do the match of the day highlights and pull all the information together for you. But you know, everybody who's joined us tonight, there were over 50, nearly 60 people on it at one point. This is an opportunity just to, you know, open your mic and pop any questions that you want to take forward to the panel. So I'll leave that for people to just open the mic and ask any questions.